Our next speaker is going to be Sheria G. Robinson Lane from the University of Michigan School of Nursing. Dr. Robinson Lane is a gerontologist with expertise in palliative care, long-term care, and nursing administration. Her current work is focused on improving the ability of diverse older adults to successfully age in place through culturally responsive and community engaged care practices, along with effective caregiver support. Dr. Robinson Lane completed her PhD in nursing at Wayne State University in Detroit and a postdoctoral fellowship in advanced rehabilitation research training at the University of Michigan Medical School. I'd like to welcome Dr. Robinson Lane. The floor is yours. Thank you.
Thank you, and thank you very much for having me. I've really enjoyed the presentations thus far this morning. And what we'll be doing a little bit is just shifting a bit to talk a bit more about the coronavirus in particular and how it has affected healthcare service delivery. And you'll have to excuse me, I have been sick the past week or so and getting over, excuse me, a bit of a cold that has mostly cleared up. So we'll see how my voice does this morning. So the one of the large challenges of the pandemic has been really dealing with multiple challenges related to the pandemic. Many of these have been challenges in staffing. In long-term care, this hasn't been limited to just the pandemic. There's been a long history of challenges with staffing, challenges with delivering consistent, high-quality care, segregated provision of services that we often don't talk a lot about when we talk about healthcare delivery across various healthcare sectors, and how our history in the US of segregation, how that has influenced care practices and how a lot of those care practices have continued today, and how they contribute to unequitable care outcomes, particularly within racial and ethnic groups. The goal for the time available today is to really try and relay the importance of examining multiple data sources to understand complex problems that are the results of multiple systems interacting. And so when you start to talk about things like structural racism, these are systemic problems. And so rather than a micro approach or an individual level approach, we really have to think more about macro approaches to problem solving and examining systems to understand the systems that are in play that are influencing these inequitable health outcomes. So the focus of this presentation, and one of the things that I think is really apparent that is always surprises me anyway, is how much when we start to dive deep into health disparities, that unfortunately our government is often one of the primary systems that has facilitated inequitable care through policy, reimbursement structures, and monitoring. But the good news is that these same sorts of systems are things that we can focus on when starting to think about how to change some of this around. So this presentation is going to focus on the long-term care sector, particularly nursing homes, care of persons with Alzheimer's disease and other types of dementia. And so because we're talking specifically about nursing homes, one of the things that I think is really important to address in the beginning is one of the most common myths that people have about older adults and care in care facilities such as nursing homes. A lot of people believe that there's a large number of older adults in nursing homes that are receiving care, and the number is actually quite small. It is only 4% of older adults that are in nursing homes and care communities. And this has actually decreased in the past few years. It was used to be closer to 7%. And so it's gone down, and we see an increase in use of home care amongst older adults. to put this into perspective, when we talk about older adults, we're talking about people who are 65 years and older, all the way up to 100 plus, right? And so when we're looking at census data from 2010, 2020, and data from the National Center for Health Statistics, which falls under the CDC, they have one of their most recent reports is from 2019. It's the report on long-term care service providers and users, and it looks at data between 2015 and 16. And there we know that when it's particular to older adults, we have about 54.6 million older adults or persons who are over the age of 65 in the US. And of these individuals, you have about 1.3 million people who are in nursing homes and about 800,000 who are in residential care communities like assisted living facilities. And so that's how we arrive at this number of about 4% of older adults that are in nursing homes. When you look at the specific population of the folks that are there, you can see that there are some individuals who are under the age of 65 who are cared for in nursing homes, but the vast majority of individuals are people who are 85 and older, and behind that are folks that are 75 to 84. And so the people who are 85 and older account for about 43.5% of the nursing home population. And people who are 75 to 84 are about 25.5% of the nursing home population. So this is a older population of individuals who tend to have multiple chronic comorbidities. When we look at the specific illnesses that affect persons, the most common health condition, as you can see here, is hypertension or high blood pressure, followed by Alzheimer's disease or other types of dementia. As this relates to the COVID-19 pandemic, which will be sort of tying all of this together, if I can highlight for you that diabetes and hypertension are two of the high risk factors for severe COVID-19 infection. And so when we think about how COVID affects multiple body systems and exacerbates chronic disease, you can see that why it makes sense that if an individual that's living in congregate living, so you're living in a space where you're in close proximity to other individuals, you have a large group of people who are the eldest of our population, and then you have health conditions that put individuals at high risk for for an infection. It would make sense then why you would see perhaps some higher levels of infection in nursing homes compared to outside in the general population. One of the things I think is also important in understanding this increased risk for infectivity of persons in nursing homes, persons with Alzheimer's and dementia, is again, keep in mind that most individuals that are receiving care in care facilities have multiple chronic comorbidities. These diagnoses that are listed here are simply their primary diagnosis that's listed. And so when you think about the ways in which COVID affects an individual's health, particularly a severe COVID infection, of course, the most obvious effect here is our respiratory system, right? And so when an individual, they can experience respiratory failure, but following a COVID infection, you can also experience quite commonly cognitive dysfunction as well as mental health issues such as depression and anxiety. And so this, of course, if you already have a cognitive problem such as Alzheimer's or dementia, it can certainly exacerbate the cognitive functioning that that person may experience. We also know that there are significant heart complications following a COVID infection, particularly these severe infections. One of the things that we don't talk about very often is the fact that approximately 1 in 5 patients end up with heart damage. This damage is the result of a lack of oxygen to the heart. inflammation of the heart, or stress cardiomyopathy, which is a heart muscle dysfunction that can affect the functioning of the heart. And you know, the role of your heart is to move oxygen throughout your body. So if the heart isn't functioning adequately, if the lungs aren't functioning adequately, then that means that the brain can't function adequately, nor can the vital organs. Some of the large effect is with the nervous system. So in addition to like what you would expect with our respiratory system, and perhaps what you might expect cardiovascular, I don't know that, again, enough attention is provided to the ways in which COVID affects the nervous system. And so the list of common symptoms are listed here. So again, you see confusion is at the top of the list, as well as stroke. And so individuals that are already experiencing cognitive impairments can see worsening of these symptoms following a COVID infection. And then the other symptoms that may seem like they aren't as challenging, like a loss of smell or taste, or trouble focusing or headaches, think about what that might mean to an individual with advanced dementia or advanced Alzheimer's, who may not be able to fully express themselves, and how that might then translate to a behavior change within a facility that might be experiencing some changes related to staffing, changes related to ability of family to come and visit as frequently, as well as variances in the individuals that are providing care. One of the recent studies that we completed that looked at hospital outcomes of individuals after they had been hospitalized for 60 days. One of the interesting things that we found was that about, for this particular study, we looked at hospitals in the state of Michigan that were participating in a quality improvement program. And so there were about 38 hospitals that accounted for about 41% of our hospitals in the state. And we had a sample size that was just over 2,000, about 2,217. And what we found was that about 15% of hospital discharges were to nursing homes. And what was really interesting that I think gets missed sometimes is that almost half of those folks that ended up in the nursing home started in the community. So 41% of the people who were discharged from the hospital to a nursing home were not in a nursing home prior to discharge. These were just people who were living their life in the community. And the other thing is that about 52%, so more than half of the nursing home residents who went out to the hospital died while they were at the hospital. So from the nursing home perspective, their number of admissions and the persons that they're taking care of didn't necessarily change significantly, but the actual people that they were taking care of did change. So the people that you sent out, only half of them are coming back, and the other half that are brand new people that have never, and I won't say never, but that hadn't been in the nursing home recently before. And so this is also significant and affecting care within the facilities. When we start to look at some of the racial and ethnic differences, and this is still within the same study that we looked at within Michigan hospitals, one of the things that you can see here by looking at this snapshot of data that we've pulled is that there's a significant difference in age. So when you look at the Black patients as compared to the white patients, there's almost an 8-year age difference between them. So what that means is that the Black patients are less likely to have Medicare insurance, and so they're less likely to meet some of the same eligibility criteria, perhaps, as a patient who is Medicare eligible, that may have had a severe COVID infection, which all of these people, if you're having an infection that warrants a hospital stay, it's a severe COVID infection. But it means that some of these individuals are going to have more access to Medicare benefits. So for example, after a 3-day qualifying stay, if you have Medicare, you can qualify for a nursing home admission to receive continuous 24-hour nursing support in a skilled nursing environment within a nursing home, versus if you are under that age and you have a difference of insurance, you may be more likely to end up at home perhaps with home care support or trying to navigate telehealth to manage care. We can also see that based on BMI, diabetes, and hypertension, that these groups did not necessarily have the same, the Black group, even though they were younger, they also had some different and more significant health concerns. And so we don't necessarily have time to jump into that in this presentation, but there's also other data that suggests that based upon zip code, access to things like grocery stores and segregation within communities is then reflected in population health outcomes. One of the other things that I would like to point out here is, as you can see, there's a large group of people here listed as unknown. Like, who is that supposed to be? And so one of the things that we identified in this work and that thankfully has been brought to light is that within healthcare systems, now this is in the hospital system, not necessarily in the nursing home system at this point, but we don't do a great job of tracking who people are or identifying how they identify themselves. And so one of the things that we were able to determine in this particular study was that when individuals enter the health system, essentially somebody else is identifying what the race and ethnicity is of the person who's entering the system. And that's how they get labeled based upon the perception of someone else, rather than having individuals self-identify their race or ethnicity. There also isn't opportunities for individuals in many instances to indicate biracial or multiracial or multi-ethnic identity. And it also identified this habit that we often have when we're looking at racially and ethnically differentiated populations to collapse groups of individuals, which then can make it harder to identify disparities across groups, which if that's what we're wanting to do, it means that we have to look at everyone that has been, all of the available data that we have. When we look specifically at the COVID-19 patient location, we can see that so even though the nursing home population tends to be older, and there are disparities or were disparities within this patient population of the individuals who between the ages of individuals, when we look before discharge, there were a lot more individuals of color, particularly Black patients, that died in the hospital as compared to white and other patients. There was a large number of Asian patients as well that had a high mortality there. But you see there was a larger number of discharges to extended care facilities amongst white individuals. And so I think that the point of this is just to say that sometimes you have to look, if the data is available, a little bit deeper to understand why there might be differences. And so if you only are looking at the nursing home admissions and see that, most of the new admissions that are coming in are white, these individuals are older, they have Medicare, so maybe this explains the disparity, you might miss the fact that a higher proportion of individuals of color were dying in the hospital, so they didn't get the opportunity to recover afterwards. The other thing that I will point out about this particular sample is that most of the more significant number of the white patients who were discharged to extended care facilities were actually discharged on palliative care. And so they were not anticipated of having a long trajectory afterwards. When we take a look at the COVID deaths that we've seen in the US, you can see that, again, the vast majority of the deaths here are amongst the 75 and up group. And when you go and look at these cases by race and ethnicity, and I'm sorry, this one here is the same, it's just a different way of showing that what a large difference it is for individuals who are over 75. This is that dark purple line across the top, how dramatically different deaths were across that age. The graph over to the left, the gray part shows you how it looks in proportion to the population. And so again, when we look at the leading causes of death of over the past from between 2019 and 2020, comparatively, COVID was not on the list. Now it is, and we see that it's affecting other health conditions that COVID also affects. And so there's more heart disease, there's a little bit higher stroke, and then we're also seeing some increased incidence of Alzheimer's disease and diabetes here. The other thing that I think that is important to note is the higher incidence of disparity of deaths across racial and ethnic groups. This, when you looking at the lines here, the top yellow line, the orangish color one here is our Black individuals who are non-Hispanic, and you see that the number of deaths exceeded by quite a bit the rest of the population. And then we have this yellowish colored line was the AI stands for American Indian. So our Native American individuals are experiencing a high proportion of deaths related to COVID. However, when you look at the nursing home, the vast majority of individuals in nursing homes tend to be white, and our stereotypical sort of picture of the ways that nursing homes have been designed have been done so in order to meet the needs primarily of that population. And so, in one of our most recent papers in research in gerontological nursing, we actually addressed particularly the needs of long-term care industry and within the long-term care sector to address health disparities within this space. And some of the things that were pointed out are variances in patient outcomes between racial and ethnic and socioeconomic and geographically different long-term care residents that has been well documented. So there's differences in care outcomes based upon whether you're in an urban or a rural setting, as well as there's very clear differences in racial and ethnic groups that also connects back to a lot of the segregated practices of nursing homes. Racism, classism, and other forms of oppression we know continue to continue, not just amongst the residents of facilities, but often amongst the diverse care staff who in many instances are serving as what has been coined double duty or triple duty caregivers. So these are individuals that are often low income nursing assistants that are caring for individuals within care facilities, but then also have caregiving responsibilities at home for aging parents with cognitive or other physical disabilities, making them a double duty caregiver, or also having young children and aging parents that they're managing at home, which would make them a triple duty caregiver. And so increasing attention to looking at the various sources of disparities and how they affect not only the recipients of care, but also the care providers is really important in starting to address a lot of these things. The racial segregation in nursing homes has also been well documented. There's a great paper that was developed by David Smith and colleagues. And there they found that Black residents were most likely to be in Medicaid, more in Medicaid funded beds. They had a higher percentage of Medicaid funded beds. These facilities are more likely to have lower staffing ratios, and then they reside in facilities with higher inspection deficiencies. And so a lot of this, again, has to do with long history of segregation policies here in the US. You know, a lot of people think about the 1965 civil rights movement, but a lot of things like with CMS didn't get implemented until the following year in 1966. And believe it or not, nursing homes were kind of exempt from that. So they paid attention to hospitals, and some inspections and things happened in hospitals to make sure that they were delivering appropriate and equal care in order to receive Medicare and Medicaid fundings. But for the most part, nursing homes really remained largely unregulated. They were not required to provide any data on admission practices or the racial or ethnic compositions of their facilities. And really the only requirement for them was to post a sign certifying that they didn't discriminate. And so that's part of the reason that we've continued to see this, as well as some of the origin of nursing homes where nonprofit nursing homes came out of fraternal organizations and religious organizations that set up places to care for their members. And so if their members were mostly white, that's who they were servicing, and then they extended later versus the for-profit organizations ended up taking on patients from the state. And so again, you see some variances there. As I noted earlier, there's been a really long problem of staffing within care facilities. This is from the Department of the Bureau of Labor Statistics. As you can see, there was a dip in staffing across most healthcare sectors that take care of older adults during the early stages of the pandemic. Nursing homes didn't do too horribly well. Folks didn't like just leave nursing homes during the course of the pandemic. I think that a lot of people felt obligated to try and stay and to not abandon the folks that were there. But as you can see, there's been a steadily decline in that space where other industries have recovered from these staffing dips, and nursing homes and care facilities have continued to see significant drastic challenges with staffing that really ultimately affects patient care and the ability to deliver high quality care. So in thinking about how do you look then at these differences in care and what are some of the data sources to evaluate? Some of the common patient data sources when you're interested in looking at data in the long-term care sector, the big one is the minimal data set, the MDS. The MDS is a federally required assessment that is done on every single person that resides in the nursing home, whether they're short-term or a long stay patient. And it provides a lot of assessment information on why they're receiving care there, and what sorts of care and what sorts of help they need. And so it has quite a bit of patient level data. CMS claims data is another place that's commonly used. The US National Nursing Home Survey, it recently changed names, and I can't think of what the current one is, but if you look up the National Nursing Home Survey, that comes out every few years and provides some information about individuals that are receiving care. And then the Medical Expenditure Panel Survey has some information about the specific nursing home components. At the facility level, the CMS online survey, this certification and reporting data set called OSCAR, and then the certification for survey provider and enhanced reporting, which is abbreviated the CASPER report. These both provide county and zip code data if you want to look at regional challenges within facilities. Looking at segregation, and if you want to understand how segregation influences facilities, one of the most common measures of segregation is this dissimilarity index. This evaluates the proportion or percentage of individuals from one race or ethnic minority group in a particular area that would have to move to a parallel racial composition of a larger macro area. Modified Thiel's entropy index is also used pretty regularly. This calculates the extent of multiracial diversity between nursing home facilities by race. And then finally, this Gini coefficient. This is often paired with GIS data to measure the dispersion. It's a measure of dispersion to quantify the concentration of inequity. The other thing is, I think, excuse me, it's good to look at mixed methodological approaches And so investigating organizations at the facility level to determine how they have or have not implemented the national standards for culturally and linguistically appropriate services and healthcare can be a helpful process for organizations and or researchers. These class standards were established by the U.S. Department of Health and Human Services, and particularly the Office of Minority Health, and they lay out 15 standards around governance, leadership, communication, engagement, and accountability. It makes it pretty clear. One of the things that they recommend is something called a health equity report, which is a process of evaluating essentially how these standards are engaged. So the three main points here are one, if you want to investigate health disparities effectively, it really requires looking at multiple data points to isolate problem sources and to appropriately look at contextual factors. COVID-19 is affecting disease progression and care delivery. And so we have to think about that in both of those ways. And then finally, racism is often at the core of health disparities. So we have to be really thoughtful and conscious about if our work is either advancing anti-racist agendas or is it maintaining the status quo. There really isn't the middle. And here's my contact information. Thank you.
Okay. Okay, well, thank you for a very, very informative presentation. Much of the material you presented was very, very new. I had not seen it before. So I'm just looking, the web, it doesn't have any Q&A entries right now. So I think in the interest of time, we'll defer. We're doing pretty good on time. So we'll defer till the general discussion between 12 and 12:15. So that's wonderful there.